So if we look at Indian Health Service and we recognize that there's a big disparity in health status between American Indians and Alaska Natives compared to the rest of the population. But even within Indian Health Service, within our regions, we see tremendous disparities. And I think cancer is probably one of the chronic diseases with the greatest degree of disparity and diversity in terms of death rates and incidence. Again, where I work in the Northern Plains, primarily Aberdeen area, but to some degree in Billings and Bemidji areas as well. Look at our cancer death rates. Billings, Bemidji, and Aberdeen, much worse than the rest of the Indian Health Service. And in the Southwest, where I used to work, much lower rates of cancer deaths. And this pattern follows commercial tobacco use incidence as well. There's a very direct correlation if you look at commercial tobacco use. Now, I'm sure most people are familiar with the commodity food program and food distribution programs on Indian reservations through the Department of Agriculture. Cigarettes used to be a commodity food. Isn't that remarkable? And in the Northern Plains, we use tobacco in traditional ceremonies. So we have had historically a good relationship with traditional tobacco. So suddenly you have an impoverished community where you're giving away free tobacco. Are people going to use it? Well, you bet they are. But it's also very addictive. The commercial form, as we know, is very addictive. And I think we have a high rate of our population that is now addicted to commercial tobacco. So when we think about this from a policy perspective, we have to look at where is the policy intervention going to make the biggest impact. So we really should follow this along kind of the cancer lifeline. And we know that the incidence of cancer really is a gene-environment interaction. So we have a genetic predisposition, which we can't do anything about, and then we have environmental exposure, which we can do things about. So if we look at even before birth, many of our people are predisposed to cancer because of genetic predisposition. And then there are precancerous conditions. Eventually, precancerous conditions turn into cancer. And then sometime after cancer occurs, the diagnosis occurs. Unfortunately for us, that's usually a long time between actual development of cancer and when we diagnose it. And then, of course, we can have hopefully cure, but if not, metastases, complications, and death. So prevention is at really 3 levels. Primary prevention is trying to prevent cancer from occurring in the first place. Secondary prevention is trying to diagnose and treat cancer after it's occurred. And tertiary prevention really is, in many cases, end-of-life care and very expensive interventions when we look at metastasized cancer. So the interventions are very different. Primary is education, screening, and primary care. Secondary intervention is oncology services, and then as we move further down the line, of course, specialized oncology services and palliative care. So where do we put our resources nationally? It's at end-of-life care. Isn't that remarkable? How much we put into treating complicated, metastasized, late-stage cancer relative to what we put into prevention. Now, is this intelligent? Is it ethical? Is it appropriate? Well, absolutely not, but this is our system of care. We don't invest nearly enough into primary prevention. We invest much more in secondary and tertiary. And there's a reason for that. The primary prevention efforts are in the public health sector, and treatment efforts are in the medical sector. And in the medical sector, they have a lot more political clout. They are in the private sector and make a lot of money off of treating disease. There's not really any money to be made at preventing cancer, but there's a lot of money to be made at treating cancer. Our system is reversed. We should make financial incentives to prevent cancer, not just to treat it after it's already occurred. So we need, in the public health sector, community and agency coordination outreach. In the medical sector, care coordination, social services, patient navigation, and aftercare. So the goals. What we want to do, ideally, is increase the time between birth and the onset of cancer. That's primary prevention. Hopefully put it out long enough where other things will happen before cancer takes hold. And when I was in my residency and doing a rotation with the oncology service, one of the oncologists said, and kind of crassly, but I guess I understand where he was coming from, he said the goal of the oncologist is to make sure the patient dies from something other than cancer. So I guess that's one way to put it, I suppose. But essentially, we just want to postpone it as long as possible. Another goal is to decrease the time between the onset of cancer and when it is diagnosed. Are we diagnosing cancer early enough in American Indian communities? Well, not at all. And there are specific policy interventions to address that. So we see disparities along that entire continuum. Disparities in incidence and prevalence, disparities in screening, disparities in funding, and you can see the whole list where we have terrible disparities. So the policy interventions are at multiple levels. We need more funding for Indian Health Service, of course. We need better prevention and screening efforts, case management, education, care coordination, and even issues in research and data. There are plenty of policy issues, and I'll get into those. So one of the things that we did over the last couple of years is start a Great Plains American Indian Cancer Policy Consortium. And the goal of that consortium, and we worked very closely with Judith Cower and the Mayo Clinic Spirit of Eagles team, is establish a Great Plains American Indian Cancer Key Stakeholders Group, identify regional cancer policy core issues, develop policy and legislative strategic plan, and then to develop an implementation strategy and follow-up plan, which is where we are right now in that process. So the people we convened from the tribes, elected officials, health departments, intertribal consortia and other tribal organizations, IHS, Mayo Clinic, American Cancer Society. I'm on the Midwest Region Board of Directors for ACS, and then state, private sector, and academic institutions. And we essentially identified 7 areas of cancer issues, kind of following that continuum of cancer care. Now, there are some cross-cutting issues that impact the entire continuum, so that was the first area that we looked at. Then educational policy issues for community, provider, and policymakers, prevention issues, then policy issues related to screening and diagnosis, policy issues related to treatment. 6th area was follow-up care, and 7th area is data and research. So if we look at the cancer policy priorities that are cross-cutting, the most important issue that was identified is just underfunding of the Indian Health Service. IHS is so terribly underfunded, you know, we don't pay for things like colonoscopy. And the most recent data that I've seen is that in this country, colon cancer death rates are decreasing because of improved screening in every population except Indians. We're not seeing a decrease death rate from colon cancer because we don't have the same access to screening, unfortunately. And where I work in the Aberdeen area, you know, we only can use priority 1 referrals under contract health services. And things like colonoscopy are not priority 1. But when that individual gets colon cancer and has symptoms because it's now metastasized, then it's a priority 1. So we won't take the steps necessary to screen, diagnose, or prevent, but we will take the steps necessary at end-of-life care. Again, not intelligent, but it's what we're forced to do because of underfunding. So that really is a big cross-cutting issue. The other was passage of Indian Healthcare Improvement Act, which did occur under the Patient Protection and Affordable Care Act. So when you hear people saying we want to repeal healthcare reform, they're also talking about repealing the Indian Healthcare Improvement Act. So something to keep in mind, something that hopefully we don't see occur.